And with that, we will move on to the next session. May I please request Dr. Amul Banerjee, Dr. Ravin Chakravarti, and Dr. Mary D. Cruz to join the panel as respected chairperson and panelists. And we are extremely delighted to have Dr. Sanjay Mittal with us right now to present his talk. Dr. Sanjay Mittal needs absolutely no introduction, but just to mention that he's the Director, Research and Clinical Cardiology at Medanta, the Medicity of Gurgaon, Haryana. Dr. Mittal, it's all over to you right now. Thank you.
Let me share my screen, please.
Yes, it is visible to all of us right now.
All right.
If you can kindly make this full screen, that works best. Thank you. Yes, absolutely perfect. Thank you.
So good evening to you all. This topic is of a big importance and very difficult to understand. Let me just clarify that many of these things which we have incorporated in this particular presentation is something which I also have learned while preparing the presentation. So first thing is, what is artificial intelligence? Obviously, it is artificial, but yet intelligence, and it is encompassing all kind of computer programs which mimic human intelligence. And that is what is the ballpark figure for artificial intelligence. It includes machine learning programs, which means the machines are then artificially programmed to learn more from what their own experience has been, which has been input by the users. And there is two kinds of learning, supervised as well as unsupervised learning, which means the data which is pumped into these machines could all help in development of new algorithms and new directions and new incidences. So this is what artificial intelligence is all about. If you look at how the things have modified, you can imagine this is the earliest ECG, a hugely obnoxious device, but that was something which led to the development of smaller scale ECGs, remote ECG monitorings. Nowadays, we have Apple watches and also wearable devices. So this is how the importance of development of machines on one side, which is obviously because of artificial intelligence included, the learning, the knowledge, the actually advancements in the technology. And the other side is also the machines have to be made learn, not whatever we know that this is PQRST, but how these ECG characteristics actually can itself be read by the machine. That was the first step. But what is the pattern of those ECG abnormalities which could lead to a prohibition of some kind of recognition or prediction of diagnosis? And also, if we actually enhance this predictive model to actually deep learning that multiple data points and outcomes analyses, ECG could actually predict the outcomes also. And I'll show you some examples. The same thing has happened in the field of echocardiography. You see, in 1985, the pipeline image processing, the pipe was considered, and that left on developing better and better and better technology. And today, we have almost all automated systems guiding the interventions, and the technology is obviously of huge use for interventions in cardiology. So the second question which I wanted to answer is, why do we need artificial intelligence? And the answer to that is a very simple thing, that we are humans, and humans under the pressure of fatigue, sleep deficit, huge burden of office as well as home, lot of unfamiliar circumstances can lead to errors. And errors also come from the lack of knowledge and training. So this is something which means that we have to go beyond what our knowledge restrictions are. So we have seen huge bit of development in pharmacological development, we all understand so. But if you look at the outcomes of cardiac diseases, it has been on a drop from a huge, horrendously high in 1968 to now in 2027-22, which is much lesser as compared to what used to be about 50, 60 years earlier. And this is all because of machine learning and new development of knowledge based on our experiences through the computing systems. This is a good data now that today what we do understand of artificial intelligence is in this format of artificial intelligence with machine learning. Everything is surrounding us is basically through the machine learning process. If we talk about the electronic health records and imaging, everything is indulged into gaining of knowledge, which we do as individuals, clinicians, but also through the machines. And this leads to automatic diagnosis, continuous remote monitoring, precision making in diagnosis. And this is something which is the output of the improved machine learning and artificial intelligence. So I would let you know that when I was looking for the literature, there has been a sudden boom in the publications on artificial intelligence, mainly the last 2, 3 years when this thing was marred by the COVID scenario. But even before that, there is a huge increase in the publications on artificial intelligence in medicine. And that is something which leads us to understand how and where we are moving. So let's come to the heart failure. There are a few points which I have taken here, and these are the indications and applications of artificial intelligence today in heart failure scenario. Let's talk about prediction of incident heart failure first. I give you an example. This is a study which was published recently in 2020. And here, children who were treated for cancers earlier on in life, and they were free of cancers, were followed up for years. And they had a recorded ECG to baseline, which was reportedly normal at that time. In this artificial learning process, various formats of ECG, almost 86 ECG features were actually computed in the follow-up program, and the outcomes were compared. It was found that if you look at the ECG features alone, there could be a model of almost 87% certainty that to predict that these people would land up later on, almost 10 years down the line, into heart failure. So although the ECGs at the baseline were not computable, but this artificial learning is now in the process of developing a scenario where the artificial intelligence in the ECG could predict the future evidence of heart failure. And this was better off than the clinical risk factors which were assessed. A similar model was basically assessed for the ECG and prediction of heart failure in normal people. And this is something based on 14,613 patients who had no heart failure at the baseline. ECG was recorded and they were followed up over a period of time. Almost 5.5% people developed heart failure in 10 years. And mind it, if you look at the ECG artificial intelligence model, it could predict with the area under the curve of 76, almost 72 to 80% correctness of prediction of heart failure. And if we combine with the clinical factors, the correctness actually went up to 0.82. This was hugely important. If we look at one of the factors we know in heart failure, atrial fibrillation, there was a study where charge AF criteria for predicting atrial fibrillation was compared to the ECG algorithm, and it was found that when we combined charge AF atrial fibrillation criteria and ECG algorithm, artificial intelligence, it increases the yield of predictability of atrial fibrillation over a period of 5 years, or to tune of precision is about 0.3. So that is something which all of us know, that ECG could be not only read at the moment, but also predict heart failure. There is another predictor of heart failure, and this is basically which is called as impedance, bioimpedance in the leg vessels. And the lower the bioimpedance, the higher the chances of heart failure. This has been shown in the literature. And this is another model of in diabetics. We know heart failure is high, but if we look at all these parameters from the Watch DM scoring system, and the age, BMI, systolic blood pressure, and all parameters, and you have a score out of this scale to give a risk score of less than 7 or more than 14. The 5 years time heart failure prediction was much higher if the score was 14 points or above. And if it was less than 7, this was heart failure was very small. So this is a predictive value of this artificial intelligence, which was based on learning in the diabetic population. The third point which I wanted to make is in the diagnosis heart failure. And again, if we look at the ECG, 95% of the patients who have heart failure do not have a normal ECG. And this algorithm actually can be designed in a very favorable fashion. The experts, as well as the knowledge acquired by the artificial intelligence, could help in better prediction of heart failure. And in this particular database, what was seen, it was matching to the T with the heart failure physicians. If you look at the heart failure with preserved ejection fraction, the yield of the machine learning driven protocol as well as the clinician combined yield about 100% sensitivity for detection of heart failure with preserved ejection fraction. And compared to the general practitioner, the blue lines, it was much better as far as validation protocol is concerned for the diagnosis of heart failure. Artificial intelligence also has led us to better classify heart failure phenotypes. In this particular study, if you can see, the heart failure, about 1,600 patients of heart failure were actually categorized according to the ejection fraction, the classical mid-ref, preserved ejection fraction, reduced ejection fraction, or the machine learned basis of categorization of six phenotypes. That means CAD, or severe valvular disease, or with no comorbidities, atrial fibrillation, COPD, or sleep apnea. And what was found was that there was no correlation or minimal correlation of these phenotypes with the ejection fraction, if you look at. However, the predictability of the outcomes was better predictable by the phenotypes rather than the ejection fraction. This is something which we know we are changing our scenario. And similar kind of classification of preserved ejection fraction is being denoted in this particular study, where three phenotypes, the phenotype 1 with the younger and lower BNP levels, phenotype 2 with obesity, diabetes, and OSA, and typical metabolic syndrome, and phenotype 3 with oldest and the highest comorbidity risk of CKD and all. And obviously, the phenotype 3 was having the worst prognosis of them all as far as the heart failure is concerned. So it not only classifies the heart failure, but also helps us in understanding, correlating it with the outcomes. This is also the outcome results that if you look at the classification of heart failure with 2016 guidelines, the addition of a deep learning model actually led to change from the high risk to low risk. This is something which is a redivision of low risk as far as high risk. So this is something which is where we are heading towards. Yes, we still have not established this artificial intelligence as a class 1 or class 2 indication, but the time is moving towards that. Artificial intelligence also helps in prediction of heart failure outcomes, and this is in enough of the studies. In one of these 429 patients, Scottish cohort, heart failure preserved ejection fraction, four different phenotypes of heart failure with preserved ejection fractions were identified, and was found that if we have a proper clustering of these fashions, we can actually predict people with heart failure with preserved ejection fraction having worse prognosis as compared to the better prognosis. The green one is a better prognosis, and the blue ones are a worse prognosis. We also have a significant difference between the value addition. Dr. Hari Krishnan did mention about the magic score, which is very commonly used, but it has been seen in DAHF's trial, the deep learning AHF trial, that if we add deep learning to the magic score, the yield is much better, almost the tune of 0.78 as compared to 0.71 of the magic score. So artificial intelligence also helps in building on our knowledge base and helping in better prediction of the outcomes. We have been having, this is where the artificial intelligence is the closest to the clinical use, whether it is external sensor, remote monitoring system is hugely under development. Internal sensor, almost all the implantable devices are using some kind of a volume sensing system and warning symptoms. In the pacemaker CRTs, we have definitely implantable pulmonary artery response sensors, left atrial pressure sensors, and all those things. And these actually give us a warning. Data comes to us through interconnectivity, and it gives warning to the patient as well as doctors to change the outcomes. So we have examples in partners HF and multi-sense study. It was seen that as the fluid built up in people who were getting close to the decompensating event, there was change in the volume status. And this is where within a week of that change, the warnings can be given. In the cardio MEMS, the champion trial, it was seen that how did the volume change status warn the change in outcomes is that it led to increase in diuretic optimization. The red line is the the diuretic optimization changes, and also the vasodilator changes in people who gave the warnings or changes were there as compared to those where the warnings were not, the blue line. So it does optimize or help the doctors to change the medications more. And also in the heart failure hospitalization study on the Link HF study, which is a wearable monitoring device, showed that people who actually had optimized the medications, they actually led to a better outcome, the green line, as compared to the red outcomes, which was the poor outcomes. Unfortunately, there has been a varied interest and results in the various trials I've noted down here. Five of them have shown no primary endpoint change, but some of them actually have. And this is one of the reasons why the present day guidelines, the ACC-HF guidelines 222, say the remote monitoring, whether telemonitoring or device monitoring, is a class 2B indication, which means in a selected group of heart failure with symptomatic heart failure, class 3 patients, it may be used, but it is still of uncertain utility until unless the doctor himself or herself is able to rectify the treatment in time. Last but not the least, the optimization of medical therapy. There have been studies that the machine learning methods can actually help in improving the outcomes of the heart failure by prompting and promoting better treatment solutions for these patients. In this particular Swedish heart failure registry, almost 44,889 patients were studied, and they were actually random forest modeling and identification predictors for 1 year survival were detected. It was seen that out of the machine learning, they could detect the 4 clusters. The cluster 1 did better with diuretics, all of them, but if you look at the ACE inhibitors, ARBs, and the beta blockers, they were better tolerated. However, cluster 2 did not do so well with the ARBs or ACE inhibitors, and the beta blockers were the drug of choice. So that means on the basis of the demographics, NYHA class, ejection fraction, comorbidities, the machines can actually guide you what drugs could be better tolerated for this map. This is what the future of heart failure therapies could be. So in this particular thing, we already know that today all the devices which are implanted have a machine learning process, and this can be incorporated into certain predictive models. Certain phenogroups which can be detected on the basis of the data, whether this person is going to be better off with CRT device or not. And that is suitability for CRT device also could be dependent on the machine learning process. In this particular study, the same thing was identifiable. So the last thing which I want to discuss here before I end, it's only 1 minute left. The artificial intelligence in heart failure is also being determined or discovered for the drug discovery process. New targets, new toxicities, new clinical trial enrollment strategies, they can be devised on the basis of artificial intelligence. The criteria can be fed into the computer. Intelligently, the machine can tell us about it. So, ladies and gentlemen, artificial intelligence can improve care in heart failure, both for prediction as well as prediction for outcomes, as well as identification of the right person for the right therapies. The treatment, unfortunately, till today is having certain limitations, and that is why it is not in clinical practice in a clear form. First of all, it depends on the infrastructure and interoperability because multiple systems are being developed simultaneously in different fashion. There is a question about the data privacy, data shift, and data errors. There is problem with algorithm bias because once you put in the algorithm, you are already biased that this is right. So that right and wrong could be misfed into the computer. Unfortunately, when we talk about deep learning, the decision making is opaque. We do not know why the decision was made, and that logic is not there. And unfortunately, also, what logic has come out, what recommendations have come out, they are yet to be proven in the randomized control large trials to be of effect. So, till that time, we have a ray of the hope in the future that artificial intelligence could come to aid to humans for a better outcome for patient care.
Thank you, Sanjay, for your excellent discussion and review of artificial intelligence. All we know that artificial intelligence or machine learning is ubiquitous with its both merits and demerits. Now its application in the field or area of heart failure, we are being most benefited. First, the prediction. AI ECG can diagnose and predict in addition to precisely diagnosing the arrhythmias. So it has got some, AI has some edge over prevailing ECG system. Now another issue is that the AI assisted or machine learning different modalities of cardiac imaging. You have discussed in detail echocardiography, but there are some nuclear cardiology is there, and MR. The application of AI in MR also will be immense help in again diagnosis, prediction, and prognostication of your artificial intelligence. I'm just highlighting the points. Another important issue, you have rightly so emphasis on the heart failure with preserved ejection fraction. This is a very heterogeneous group. We have different phenotypes, but by artificial intelligence, we know that rather from treating this group, we can predict how this particular phenotype will do in future, or we say the prognostication. So, though artificial intelligence in clinical application is not so much being encouraged, it is to be also, but we think that future application with more refinement, more deep learning, more acquisition of different clinical and other data will have the immense help from artificial intelligence. Of course, its application in coronary angiography, which is a part of the assessing the heart failure, we can have a better idea. With this brief summary, I find Dr. Robin Chakraborty. I request Dr. Robin Chakraborty to elaborate some points. Again, I give you thanks for just reviewing so many up-to-date data on rather a bit hazy area in our heart failure area. Robin Chakraborty, please.
Thank you, Dr. Banerjee. I think it's a great talk by Sanjay. Worth listening to it. I mean, as you said very rightly, what I understand that what is interesting perhaps that we all know that heart failure is basically a clinical syndrome. But during the management of the disease and for the subsequent follow-up, we determine the outcome of the disease process. There are multiple substrates which are responsible for this clinical syndrome. So therefore, in the management process, there is a kind of a number of data sheet which comes in front of you when you see a patient of heart failure, and those data sheets are important determinants of prognosis, of the response towards therapy, and also the non-responding to the therapy. As we know that when you apply implant device in certain subgroup of patients of heart failure, then there is a small group of patients who do not respond to those device therapy. Now, the question will remain, and I think it will be very challenging for the clinician as well as eventually the artificial intelligence to incorporate that what are those parameters, how artificial intelligence can dissect that data sheet and find out that, well, this information is important for the categorization of these heart failure patients, that it will improve on medical treatment or it will improve on a long-term basis in terms of prognosis, and also the response rate and possible positive response. And finally, this subgroup of patients, because of these hemodynamics, because of this substrate, patient may not respond to the conventional treatment, or be it medical treatment, device treatment, or even beyond that. So that is a kind of my viewpoint. And what are your thoughts, Sanjay, on this regard? That is one, and then I think you touched upon the possible fallacies and limitations of artificial intelligence. So, and the human brain, although it has its own limitation, but human brain has an ability to judge the individual variation of patients, because all heart failure may not be same, because it has got a clinical variation, it has got a geographical variation, it has got a economical variation, social variation. Those things, when we physicians see patient, we consider and determine the therapy of the patient. Artificial intelligence, I am not sure whether that has got the ability to understand the geographical difference, the ethnic difference, the socio-economical difference, and then decide that that is the right kind of prescription for that particular patient. What are your thoughts on that? Thank you.
Yeah, you are absolutely right. So that is where the development of artificial intelligence is also happening. You know, almost all the devices we are talking about, there is a model A, which was today. And if you talk about tomorrow, the model A is already a past tense. There is already an artificial intelligence imbibed into the new model. And that is something which is under the screen going on for last so many years. Dr. Amal very clearly said about the MRI. I was working on that. Why? Because I specifically didn't speak about it. Why? Because MRI is totally artificial intelligence based. You have scar imaging, you have the volume imaging, you have the same strain rate imaging going into it. Everything is a conglomeration of various programs imbibed into the MRI reading system. And Dr. Ravin was very clear about it. Besides prediction, I think the biggest change which I thought is important to understand, what we talk about ejection fraction, the study showing that despite the fact that ejection fraction, no ejection, normal or preserved ejection fraction or low ejection fraction, there is study or data suggesting very clearly that the phenotype based treatment or understanding predicts the outcomes better. So that means there is going to be, we have been talking about ejection fraction as a Achilles heel in our clinical sense. So we possibly are looking at redefining heart failure. And I'm quite sure what we do not see in the future, within 5 years, we would have a bombardment of new data, which would be impelling us to actually change our scenario and concepts completely. So what I'm trying to communicate is artificial intelligence is under the background actually guiding us. Development of the science of improvement in treatment for heart failure patient, recognition of heart failure patient, prediction of heart failure patient is all artificial intelligence based. And that is something which is on the background happening. The time we realize there is a query that at some point in time, maybe 5 to 10 years, we would not require cardiologists, because there would be robots doing all the procedures, there would be computers making the diagnosis, identify which patient population would do better with such in kind of patient treatments. So, I mean, there is a huge argument going on with that. Till that time, we are safe. So at least in our age, my age, in your age, we are
Thank
safe.
you.
Artificial intelligence is not going to take us over.
Thank you.
Thank you. Thank you,
Dr.
thank
Mittal.
you, respected speaker, respected chairpersons, and the panelists. Thank you. And with that, we will be moving on to our next session.